Uh, Thank you. Thank you very much, Dr. Nitin, for this nice introduction. The topic given to me, I think I'm audible.
Yes,
The
yes,
top,
absolutely.
yeah, the topic given to me is immunization in preterm low birth weight babies or sick babies. So this is a very important topic and also a very interesting topic. Although there is not much that we might be adding to our existing notion about the IAP schedules of vaccination or schedules of vaccination for that matter, may it be from any other country. If you take roughly an example, I mean, with respect to low birth weight babies and preterm babies, the lower and middle income countries produce large number of low birth weight babies. Usually it is seen, if you take the example of India, at least 15%, 12 to 18% of the babies who are born are preterm, and babies to the tune of 25% can be small for gestational age. So it is very interesting and very important for us to understand how do we have to proceed with respect to the vaccination of these babies. So for preterm babies, we have various things that we usually follow upon. One is the assessment of gestational age. Gestational age assessment is done by doing, the correction of corrections, or sometimes we call post-menstrual age, and we tend to calculate the corrected gestation age beyond that completed 40 weeks. Likewise, for things like assessment of development, we take these corrected age. And for things like maybe complementary feeding, we take the calendar age or the chronological age. So there had been a lot of doubt or skepticism with respect to uh, preterm babies. What age should we take, whether it is a chronological age or the the corrected age with respect to immunization. So in this discussion of ours, I'll be trying to throw light on, I mean, what is so important or what is so significant thing about preterm baby with respect to immunity. What are the adverse events that we see following immunization? Are they same as term babies or any other infants? We'll see some of the recommendations and individual vaccinations, and a little bit about cocooning. No, firstly, with respect to immunization of preterm babies and low birth weight babies, why are these babies are at risk of infection? They are not only at increased risk of infection, they are also the incidence of infection as well as the severity increases with respect to the gestational age if it is lower side. So there is a lot of apprehension, a lot of fear amongst these babies with respect to vaccination, mainly firstly because of lack of knowledge about the safety as well as effectiveness of the vaccine. And it is important for healthcare workers and parents to have fair understanding about this. And additionally, there is also fear of adverse events or increased cardiorespiratory events following immunizations, which is also a known fact that these babies might have severe adverse life-threatening events. But then it is not as severe as, I mean, incidences are not as big as to make sure, which is restricting us to take the baby to the hospital for vaccination. So there have been a lot of recommendations which have come up, recommendations from CDC, recommendation from WHO. There are recommendations from AAP as well as IAP with respect to vaccination and follow up these babies in the first 72 hours of age. So firstly, why are these babies are suffering from low immunity, or why are these babies are at risk of infection? So we know that skin is the largest organ of the body. So skin forms a integral or a barrier against infection by protecting all the surface of the body. So in the skin, the stratum corneum is very important. It is the main membrane beyond which multiple layers of the skins do follow. This formation of this stratum corneum usually happens around 32 weeks of gestation. And if a baby is born preterm, it will usually take around 2 weeks for its keratinization, and then the formation of a tough substance which will prevent infection. Secondly, with respect to gastric acidity, as we all know, stomach, in the stomach there is production of HCl, and this HCl offers certain amount of immunity against the live organisms which enter into body. So amount of acidity that is produced by these babies is little lesser and predisposing the babies for various kinds of infection. So with respect to the secretory immunoglobulin A, which are usually produced in the mucosal barrier membranes, whether it is in the gut or in the bronchial area or any other mucous membrane, the production is very less, very minimal till the gestational age of 29 weeks, beyond which the production keeps on increasing. And then these babies, over a period of time, the amount of IgA levels which are produced keep on increasing drastically. And with respect to the complement activity, the complements are the ones which participate in humoral immunity, as well as both even in the cell-mediated immunity. So these complement levels are low in numbers, and there is also decreased neutrophil phagocytosis and adhesion and whole of sequential things that neutrophil does. So which is why these babies are at risk of infection. Additionally, the CD4 counts, CD4 cells, their ability to function normally is also far too less. The cytotoxic action of CD8 T cells is also not appropriate. We can say it might be appropriate for that gestation age, but it is not as good as term baby. So additionally, most amount of antibodies that a baby acquires is usually in the last 3 months of the gestation. So if the baby is born preterm, based on the degree of prematurity, amount of antibodies that the baby acquires from mother is far too less. So this is why these babies are also lack in the certain amount of humoral immunity. And then the intestinal microbiota, which are actually usually derived from mother's skin or mother's birth canal or mother's milk. Usually babies are deprived of these things because usually preterm babies are born by cesarean section. They do not come in contact with the skin of the mother. They do not have sufficient time to come in contact with the skin of the mother, because as soon as the baby is born, if the baby is sick, baby is immediately shifted to the NICU. And the probiotic organisms or the commensal organisms, which otherwise harbor in a baby, term baby, and which help in stimulating the immunity of various types in the body, are less. So based on these things, there are various aspects of immune system which are less in preterm babies. Usually in general, the antibody response after vaccination is less in preterm babies. But then the antibody response keeps on increasing with the increment in the chronological age or the gestational age or the birth weight. So postnatal maturation usually, which happens because of the environmental exposure to the antigens, it helps in contributing in production of antibodies. And over a period of time, there is increment in amount of antibodies that a baby produces. So now there is something called as, there have been many studies, there has been fair understanding about amount of antibodies that are produced by the preterm babies after vaccination. And as we see in the term babies, if we compare the amount of antibodies or amount the immunity that antibody raises is far too less. But the fact of the matter remains in the statement that even these lower antibodies are sufficient enough to produce appropriate amount of immunity that the body requires. So this holds good even for babies who are very sick, babies who have been on long-term ventilation, who are suffering from chronic lung diseases, babies who have received dexamethasone or hydrocortisone for various scenarios, could be because of prevention of RDS or chronic lung disease. All of these babies uh, are, they all of them produce a certain amount of antibodies, which are sufficient enough for appropriateness of the prevention of infection. So vaccines, I mean, there is also certain skepticism with respect to vaccine dosage. Normally, there are standard dosages that we have for the vaccination. For example, we have 0.5 ml of hepatitis B and all other DPT 0.5 ml. And likewise, for most of the antigen that we give, vaccination that we give, there is standardized volume. There is a lot of skepticism with respect to, should we give same amount of volume to these preterm babies, low birth weight babies, or should we reduce the volume based on their gestation or based on the weight? But it has been proven beyond point, the amount of the dose of antigen that we are giving has to be same as we give in term babies. So with respect to adverse events in preterm vaccination, so there are many studies which have shown cardiorespiratory events, which are, manifested more in smaller babies, whether it is extremely low birth weight babies and very low birth weight babies. And these cardiorespiratory events can be life-threatening. And this is the basic apprehension amongst the healthcare workers why they would want to avoid the vaccination. So these cardiorespiratory events could be apnea, which can happen within first 24 hours after vaccination. There can be, history of bradycardia, sudden cyanosis. There can be all those common symptomatology that we see in term babies, like redness, swelling, fever, all those things. But it's seen that usually whenever the apnea happens, it is seen on the smaller, younger babies, gestational age, if they're less than 34 weeks, usually within the first 24 hours, usually when the babies are less than 2 kilos. And it happens in those babies who are very sick during the NICU stay or who have had history of apnea in the previous vaccination. So it is important when these kinds of risk factors are there, it is important for these babies to be monitored for first initial 48 hours when the baby is still in the hospital before discharge for the adverse events. So there are certain recommendations which we have to follow. Usually, in Indian scenario, we have these vaccination schedules wherein we have first vaccination at 6 weeks, 10 weeks, and 14 weeks. In Western world, it is usually as 2 months, 4 months, and 6 months. Even in Indian setups, we have, some of the centers do follow 2nd month and 4th month and 6th month vaccination schedules. So if a baby is admitted in neonatal intensive care and is still in the hospital during the first vaccination time, let's suppose whether it is 6 weeks or whether it is 2nd month, they should receive all inactivated vaccines which are recommended for that age. So usually when we say medically stable infant, it is defined as those babies who do not require any ongoing management of serious infections or metabolic disease, or they are not suffering from any renal, cardiovascular, or neurological or respiratory illnesses, which actually means any growing preterm stable baby. These babies, if they have to be there in the hospital for a certain duration of time, we have to give benefit of vaccination and we have to monitor them in the first 24 hours or 48 hours for this specific vaccination related adverse events. So all immunizations should be required for that. All the immunization required for 2 months of age can be administered simultaneously to preterm baby. Like we give diphtheria, pertussis, tetanus, hepatitis B, and H influenza. But this rotavirus, oral rotavirus, which is usually the live antigen, we should avoid giving this oral vaccine if the baby is going to continue to stay in the hospital. If we are planning to discharge a baby, just before discharge, we can give this oral rotavirus vaccine and then follow up the baby subsequently. Usually what happens because of this oral rotavirus vaccination, there can be horizontal spread of rotaviral antigen amongst the NICUs, which is why we tend to avoid this. But most of other, all of other diphtheria, pertussis, tetanus, H influenza, and hepatitis B can be continued in the hospital setup and can be given in the hospital setup itself. So number of injections, usually at 2 months of age, which is again maybe at 6 weeks of age, can be minimized by using combination vaccines, because we know that muscle mass is very less in the tiny babies, and it becomes a little difficult to administer multiple injections. We sometimes have supply of only diphtheria, pertussis, tetanus as one injection, and H influenza as second, and then third one is hepatitis B, and then we also have to give pneumococcal vaccination. So if we are not able to have supply of these combination vaccines, we can space these things up. We can give 2 sets of vaccination with a gap of 2 weeks in between. So this recommendation is, most of these recommendations are from Red Book, which is again a book of AAP, and injection, if we don't have access to injection sites, if we don't have good muscle mass, we can space up the vaccination by 2 weeks and subsequently follow. As we keep on following, we can subsequent visits, we can give vaccination in the similar scenario, a similar way, by giving 2 weeks gaps, or calculating the last dose from that day onwards, we can continue to give the vaccination. And needless to say about the choice of length of needles and other things, we can do individually based on the muscle mass. We can choose smaller and thinner needles with respect to the vaccination. So preterm baby and low birth weight baby vaccination, routinely, if I have to say, the regular vaccinations, we have BCG and oral polio, even injectable polio, hepatitis B, diphtheria, tetanus, pertussis, H influenza type B, rotavirus, and pneumococcal vaccine, which we give. And in special considerations, in scenarios wherein there is outbreak of flus in the family, we tend to give influenza vaccination to babies who are usually crossing 6 months. And we give palivizumab to babies who are suffering from chronic lung disease, or babies who have had cardiovascular issues, whether it is ligation issue, duct ligation issue, or a cardiovascular disease, congenital heart disease. In these babies, we tend to cover them with RSV immunoglobulin, which is palivizumab. So with respect to, now coming with respect to the individual vaccinations, the first one is BCG vaccination. As we all know, BCG is given for against the tuberculosis. And as per there are many guidelines with respect to this. Usually it is followed in those countries where the incidence of tuberculosis is high. And usually Asian countries do follow this, and has to be given to babies at around 34 weeks of corrected gestation age. Indian Academy of Pediatrics recommends administering BCG to stable babies at the time of discharge. At least we have to see, I mean, most of the centers follow this guideline of achieving at least 35 weeks of gestation, at least 1.5 kilos, and consistently gaining weight, and mother is confident of feeding. When these discharge criteria are met, usually we discharge these babies. So it is good to give them BCG vaccination before discharge. So safety and immunogenicity of BCG vaccination amongst preterm babies has been proven beyond doubt, especially in the first week of birth. And there has been a strong backup of meta-analysis and multiple randomized controlled trials. So it can be given, this vaccination can be given in stable preterm babies or sick babies now who are stabilized just before the discharge. With respect to polio vaccines, Indian Academy of Pediatrics recommends that birth dose of polio can be effectively given to low birth weight babies and preterm babies after stabilization, and preferably at the time of discharge. And injectable polio vaccination or combination vaccine should be used on a regular schedule as per the chronological age, not the corrected gestation age. So we can give polio at the time of oral polio drops at the time of birth, even if the baby is in low birth weight. And subsequently, as per the chronological age, we can give combination vaccination wherein injectable polio vaccine is part of this. Coming to hepatitis B vaccination. So we have two scenarios. Let's suppose two scenarios, which is wherein one scenario is baby is less than 2 kilos. In the second scenario, where the baby is more than 2 kilos. Usually, when the baby is more than 2 kilos, we follow standardized normal, schedule. In babies who are less than 2 kilos, if the mother is hepatitis HBsAg negative, the first dose of hepatitis B vaccine can be delayed till first month of age or during discharge, whichever is earlier. And if the baby is less than 2 kilo, but mother is hepatitis B positive, then the vaccination should be given along with hepatitis B immunoglobulin within first, we say 24 hours for term babies. In preterm babies, we are more, I mean, we would want it to happen as early as possible. So Red Book advises usage of hepatitis B immunoglobulin within 12 hours after birth. And when we give this hepatitis B immunoglobulin to a baby whose mother is hepatitis B positive, this should not be counted in the normal schedule. So subsequently, we have to give 3 more doses as per the recommendations. Usually we give at 2nd month, 4th month, or 6th month, or 1.5 months, 2.5 months, 3.5 months. So with respect to immunogenicity, if you have to say, hepatitis B vaccine is the only vaccine which has a very low response with respect to immunogenicity. The immunogenicity ranges between 45 to 55, 45 to 85, with the average being around 50 to 60%, as compared to 90 to 100% when it is given in term at birth. But still, it is sufficient enough for a baby to be protected. So coming to DTP, diphtheria, tetanus, and cellular pertussis. Usually, pertussis, whole cellular pertussis causes a lot of adverse events, can cause adverse events, and acellular pertussis is advised for preterm babies. Can be given as per the chronological age or just before the discharge. And for the caregivers also, caregivers like the mother who has, during her pregnancy, if she has been optimally vaccinated against Tdap, then there's no requirement. But if there is not, usually we give two doses of vaccinations between 27 weeks to 37 weeks, 36 weeks of gestation during pregnancy. But if she has not been vaccinated, she also need to be covered with this. And in babies, we can club up all of the vaccinations together and give as per the chronological age. We have already understood about the rotavirus vaccination, that we should not give rotavirus vaccine orally when the baby is going to continue to stay in the hospital, but should be given just during the discharge. But then there are certain things which we need to also to understand about the rotavirus vaccine. Usually many recommendations say that rotavirus vaccine is ineffective beyond 6 months of age. Some of the agreement is upon on this at 8 months of age. Even if we count 8 months of age as a cutoff beyond which we need not, or we cannot, or there is no use of giving rotavirus vaccination. So 3 doses of rotavirus have to be finished before this 8 months. So if for that to happen, the first dose of rotavirus should be administered from 6 weeks through 14 plus 6 weeks of age. Maximum age for first dose is 14 weeks plus 6 days. Beyond that, if we cross, the 3 doses cannot be given and underdosing is ineffective. Coming to pneumococcal vaccine, so preterm babies, just like hepatitis B vaccination, show very low antibody levels against pneumococcal disease, but it is still agreeable to give this vaccination because it produces at least sufficient amount of immunogenicity, which is going to help. So both 10-valent as well as 13-valent vaccines are licensed for advocation in preterm babies as per the chronological age. With respect to Haemophilus influenza, there is nothing new about this. Again, this vaccination has to be clubbed with the other vaccination and has to be administered according to the chronological age. So with respect to influenza virus, we need to give at least 2 doses of inactivated influenza B vaccine administered at least 1 month apart should be given to all babies who are 6 months and above. So if a baby is born, let's suppose at 24 weeks, by the time this 24 weeker becomes 40 weeker, which is a term age, total time duration that baby has to go through is around 3 months, from 24 to 40 weeks is or 16 weeks. It's almost 4 months, 3.5, 4 months. So we have to calculate include all of these things, all 3.5, 4 months, and add 2 more months. I mean, that is a chronological age when we have to give the influenza virus. So less than 6 months, it has been seen that vaccines are inefficient and ineffective in terms of production of antibodies. So we advocate usage of influenza virus vaccine only after 6 months of age. So just to sum up, BCG should be given at the time of discharge, and if the baby is stable, can be given at the time of birth itself. Polio, if oral polio can be given if the baby is stable. If the baby is not stable, should be given at the time of discharge. Hepatitis B vaccination, if mother is negative, can be given at the time of discharge or 1 month of age, whichever is earlier. And hepatitis B vaccination in a scenario when hepatitis B mother is positive, then we have to give vaccination within first 12 hours, and we should not count in the series of vaccination. DTAP and Hib, pneumococcal vaccine and influenza vaccine, all of them have to be given as per the chronological age. We have to combine DTAP, Hib, and pneumococcal vaccination, and also the injectable polio vaccine. And we have to give these combination vaccines because of because of the fact that we have to give minimal pain to the baby, and baby doesn't have sufficient amount of muscle mass for having multiple site injections. And secondly, because of fear of adverse events. Influenza vaccine has to be given at 6 months of age as per the chronological age. So coming to this immunoprophylaxis in the special scenarios, like usage of palivizumab. So basically it is monoclonal antibody against RSV F glycoprotein. It is used for prevention of serious RSV lower respiratory tract disease in children who are at risk of RSV disease. Usually, this does not interfere with the response to routine immunization, because many times we give, we presume that we are giving antigen and that we're waiting for the antibodies to be produced from the body per se. And things like palivizumab, which per se are the monoclonal antibodies, do they interact with the normal process of antibody generation in the body, or do they nullify the antigen that we give? Is some of the times a doubt that comes into our minds. Usually measles, mumps, and rubella, varicella, these are the routine vaccination that we give around that point of time, usually 6 months, 8 months, 9 months. These viruses are not nullified by palivizumab. And in babies who are born before 29 weeks of gestation, and in babies who have issues of heart, like we discussed before, chronic lung disease or hemodynamically significant heart disease, they are more at risk of severe RSV illness, or they are even more risk of death because of the RSV. So it is important for us to give the benefit of doubt by give the best protection by offering RSV glycoprotein antibody, monoclonal antibody against RSV. So there is something called as targeted immunization or cocooning. Basically, these are special scenarios wherein we are giving vaccination to babies whenever we have increased incidence of a disease illness. For example, this is mainly seen in scenarios like pertussis or influenza vaccination. Suddenly, when the baby's parents or grandparents or anybody, maybe caregiver or siblings, is suffering from issues like cough, which is whooping in nature, or flu-like illnesses, we tend to give vaccination. So usually these babies, we have to give protection against the pertussis kind of scenarios or influenza flu kind of scenarios in the special scenarios. So the recommendations, the references of various recommendations that I used in this book are from IAP And we also there's a good fair understanding that we can deduce from Red Book, NEO reviews, AAP's common queries about immunization preterm infants, and also from immunization from low birth weight babies and preterm infants, which is 2017 Immunization Advisory Center. So thank you very much for your patient listening, and I'm open for any queries and concern that we can discuss now.
I think if I'm audible, there are no questions, sir. We will close the session. Yeah, there is a question from Rasman. Babu sir, I'm making you a host. I think if you are able to hear me, there is some signal issue at my end. I have allowed this. So unmute, you can unmute yourself.
Yeah.
Right.
Any questions? Any questions? I think we'll wait for 5 minutes. Anybody has questions, we can post or you can ask also.
So also, I will add you to the group in case
Okay.
those who view this recording, they can
Okay.
post the questions later on in the group. On the group, Rasna ma'am has kept one comment about RSV. For RSV, the new recommended vaccine is Nirsaniva one dose before 8 months of age.
Yeah.
And one question from Dr. Nishiganda is how much gap will be between IVIG and live vaccine?
So people say it has to be around 1 year of age, roughly. But then again, for live vaccines, it is different, and attenuated vaccines, it is different. Usually for live vaccines, 1 year is sufficient, and attenuated vaccine, some people suggest 2 years, but the recommendation is 1 year is sufficient.
I request all, sir, you have to, as you are the host, you have to request all to please mute themselves.
Okay.
Nitin, can I just butt in?
Yes, ma'am, please.
Yeah, for live vaccination and IVIG, it is 3 months.
Yes.
Okay,
In last
and for
session,
other
also we have
vaccines, skilled
discussed.
vaccines, even 3 to 4 weeks you can give. But for the live vaccine specifically, the gap should be 3 months.
Yeah.
Even PCV 14 is approved for preterm babies.
Okay. If there are no more questions, I think we will take other questions on the group, ma'am. And Babu sir, I will add you to the group. And like in last session, we have this question of live vaccine and IVIG. In Purple Book 2022 clearly documents this duration of 3 months as well. So if we will be closing this session for today, and we will be taking all other questions in the chat room.
Okay.
Thank you, Babu sir.
Yeah.
Thank you, Western ma'am, for pitching in. Thank you everyone for joining.